Okay, so in this section we're going to discuss how we would examine a patient where we suspect that there's diplopia with a strabismus. And here are the topics that we're going to cover, and we're going to start by discussing assessments of the corneal light reflex. So this is the picture that we saw before earlier in the lecture, and I think everyone would agree looking at this that the eyes do not look like they're aligned with each other. And the question is, what are we looking at specifically that tells us that the eyes are not aligned? So an answer that will often be given first by a student is they'll notice that there's a lot more sclera showing over here in the right eye than in the same location in the left eye, and that this asymmetry gives us an impression of the strabismus. We would say the same thing about the other aspect of the eye as well. Again, a lot of asymmetry. And that's true, but you can often be fooled on that. Sometimes people can have unusual shapes of their eyelids, for example, that can give you the impression that there's an asymmetry or a misalignment when there is not. The most accurate thing to look at is the corneal light reflex. So over here we see a white dot, and this is probably if someone was taking a picture of them with their flash, for example, or was holding a light in front of them. This is the light reflex that's coming from that camera bulb. And the important thing to notice, of course, is that it's lying in different locations on each eye. So this eye, the light reflex, is pretty much in the center of the pupil. It's a little bit elevated. Whereas in this eye, the light reflex is completely outside the pupil itself. And this is what you should be looking at when you're making this decision. We would assume, for example, that this patient is fixating with their left eye. That's the eye that they're using to focus, and this is right now the eye that's misaligned, the right eye, because of where the light reflex is. And we'll move forward now. So when we look at a patient like this, if this gentleman comes in and says that he's complaining of diplopia, and we looked at the corneal light reflex, quickly at least, we would probably assume that it looks about symmetric, that it's a line in this case that's starting from the side and coming to the center of the pupil. It might be a little bit off, a little bit more pronounced here, but it's pretty symmetric. And the question would be, is it fair to assume, therefore, that this person doesn't have a strabismus if the corneal light reflex looks very symmetrical? And of course the answer is no. And the answer is no for two reasons. First of all, there might be a very subtle misalignment here that we're not noticing, so that the corneal light reflex in terms of its sensitivity is limited. And if someone has a misalignment probably by 1 or 2 degrees, the corneal light reflex is still going to look to you, the observer, to be very symmetrical. The other issue is that this might mean that the eyes are aligned when the person's looking straight ahead, but when they look off to the sides, for example, the corneal light reflex might become very asymmetric. So just having a situation where it looks normal now does not mean that you've excluded the possibility of any form of strabismus. So of course the next major step that you would take is to assess the eye movements. And in this cartoon, for example, the person's looking straight ahead here, looking off to their right, looking off to their left, up and down, and looking in diagonal directions. And we would observe how the eyes are moving in each direction. And if there's a very obvious strabismus, we'll see a clear limitation of how one of the eyes moves. But once again, you can have a lot of situations where there is a strabismus and the eye movements to the observer will look very full. And I think that this makes sense if, for example, someone's developed a very mild but significant 6th nerve palsy where the force of the lateral rectus has decreased from 100% to 95%. Of course, that is something that's important that needs to be addressed and noted by we shouldn't miss that as clinicians. But if you assess the eye movements, it would be very difficult, I think, for a clinician to notice any sort of change in the eye movements when there's just a 5% decrease in the force of the lateral rectus activity. The eye movements will still look very full. So that's not a good choice in terms of looking at something when something subtle is going on. And that's my goal here, is to teach the students how to pick up when something subtle is going on with a very subtle strabismus. So now we're going to talk about increasing the sensitivity a little bit more with something called a cover test. And here in this cartoon, I'm going to demonstrate what the idea is. So you ask your patient to look at a target at the other end of the room. In this case, it's an E on a letter chart. And the patient's looking, and maybe in this case, the eyes look very aligned in terms of the corneal light reflex. And here's what's actually going on. The right eye is looking right at the target. The left eye, however, is a little bit off target, very slightly, and it's would be very difficult for the observer to notice it. But it is a little bit off target. The examiner then goes ahead and covers up the right eye. And since we're telling the patient that they have to keep looking the whole time at the target, at the E, what has to happen now? Well, the left eye needs to move. And it's that movement that occurs when we cover up one eye that tells us that there must be a misalignment between the eyes. There must be a tropia. So again, we cover up one eye and we look for movement of the other eye. One of the limitations of the cover test is that it doesn't allow us to pick up aphoria. So we'll remember that there's aphoria is a situation where the eyes have a tendency, they want to be misaligned with each other, but the brain with effort is able to keep them aligned. Why is it relevant to pick up aphoria? Because sometimes we have patients who come to see us where they're developing intermittent double vision, particularly, for example, at night when they're tired. And that's because when they're tired, the brain lacks the strength to keep the eyes in alignment, and they therefore develop diplopia. Of course, as an aside, with a story like that, we would be concerned about myasthenia gravis and normally test for it. But often one of the reasons can simply be that the phoria itself is decompensating and that the patient is experiencing, again, a transition from aphoria to atropia when they become tired. So if that's the case, we want to see, do the eyes have a tendency to become misaligned? And the alternate cover test there can fool us. We go ahead and do the alternate cover test, and we see no movements of the left eye, and then we go ahead and cover up the left eye, and we see no movements of the right eye, telling us that the eyes are aligned. So we need to do something a little more sophisticated to see if there's a tendency for the eyes to become misaligned. And this brings us to the alternate cover test. And watch what's done here. So again, we start off with the cover test, and it's negative. We don't see any movements. And then we begin to move the occluder back and forth. And as we move it back and forth, now we see movements. And why is this happening? Because in the case of the brain in its effort to keep the eyes in alignment on another, we'll just come back to this slide. The critical thing to note here is that there's an overlapping visual field from each eye. And the brain uses the clues, or tries to use the clues of what it's receiving from both eyes to fuse the images and align the eyes with each other. So that the only way that the brain is able to keep the eyes pointing in the same direction is it needs to try to match the picture coming from each eye. And if you deprive the brain of being able to use the input from both eyes together, if you're only giving it input from the right eye and then only giving it input from the left eye, then it can't use this system of trying to match the overlapping signals to try to bring the eyes in alignment, and the eyes drift off to wherever they want to go. So here we have an example of a patient who has an exophoria. In this case, her eyes want to be slightly drifted apart from each other. It doesn't bother her normally. And we'll see as the examiner does the test how the cover test is negative, but the alternate cover test shows some movement of the eye. Okay, so I just want to remind you, as we're watching the video, one eye will be covered And we have to look at what's happening with the other eye. Does the other eye, the one that's not being covered, move at all as the other one is covered? If it doesn't move, then there's no misalignment that's being shown. If we see any sort of movement, then that suggests that there is a misalignment. And you'll see that at the beginning of the video, as the cover test is being performed, that the other eye, the one that's not occluded, doesn't move at all. But as the examiner switches to the alternate cover test and starts moving the occluder back and forth, that you'll start seeing that as that happens, that the other eye does make a movement. It's a slight movement, but it's a very significant movement. So let's see that now. So we're not seeing any movement right now as the cover test is being performed. And now the alternate cover test happens, and look at that movement. It's just each eye moves slightly inward. And that tells us that there is a misalignment. In this case, it's an exophoria. I don't think that it's critical for the medical student to be able to define what's wrong with the movement. It's just the fact that you've picked up the movements, from my opinion, is the finding itself. As kind of a bonus question, a medical student might say, if the eyes are moving inward, why would that be an exophoria? And the idea that I just want to explain there is that what's happening is that as one eye is being occluded, the eye wants to drift outwards, and that's what it does. It drifts outward. Then when you force the patient to use that eye to fixate on a target, since the eye is drifted outward, how does it have to move? It needs to move inward to go back on a target. So in some ways, the way that the eye is moving, suggests the opposite in terms of where the deviation is. If the eye, as we uncover it, moves inward, then it's an exo deviation. If it was moving outward, then it would suggest that it's an ESO deviation. If that doesn't make sense, again, I think it's just beyond the scope of the lecture anyway to deal with. So the last component of the examination that we should talk about is head tilt and turn. And in some ways, this is one of the things that should probably be first addressed as part of the examination. So we look at this patient's eyes, and if we just look at the corneal light reflex, it looks a little bit asymmetric. So here in the right eye, it's more on the nasal aspect of the pupil, and that would mean that it should be displaced over here. If we say that's on the right side of the pupil in this eye, then it should probably, if it was symmetric, be on the right side of the pupil in the left eye, but it's kind of on the right side in both cases, so there is a little bit of an asymmetry. But it's not so marked. But look how the patient is holding their head. They're turning their head to the left. And what happens if we straighten out the patient's head? We see a very dramatic misalignment that develops. Here's the corneal light reflex in the right eye, and look at how asymmetric it's become. And so this patient actually has a fourth nerve palsy, and because of the fourth nerve palsy, they've learned that if they turn their head a certain way, that they can minimize the misalignment, and this is the way that the patient normally walks around. And so the first thing that we really should do, even sometimes before looking at the corneal light reflex, is ask ourselves, is the patient looking at us with a straight head? Is there any sort of face turn or tilt of the head to one shoulder or another?